tiempo, vamos a comenzar de una vez con la presentación de la doctora María Argyropoulo de Grecia. Ella nos va a hacer la presentación en inglés sobre un tema súper interesante para los neuroradiólogos y los radiólogos en general, los radiólogos pediatras, un tema que es bastante difícil y del cual aquí estamos todos para aprender, dada la experiencia de la profesora. El tema se llama Resonancia magnética en hipoxia, isquemia del cerebro neonatal, recién nacidos de término y prematuros. Los dejo con la doctora.
Good afternoon, ladies and gentlemen. It's a great pleasure to be here, and I would like to thank the organizing committee for giving me the opportunity to come here. I was trying to understand Spanish, some words, but okay, next time I will be better in Spanish. So the purpose of this presentation is to understand the role of brain sonography and MRI, because these are the imaging modalities. To become familiar with the differences in the brain between preterm and full-term babies, to learn about the imaging patterns of hypoxia ischemia in premature and full-term babies. So what we dispose in examining those babies, there are two modalities. It is ultrasound and MRI. And when we are talking about neonates, it is important to remember that ultrasound is the first and the best exam to start with, and then we can continue with MRI. What about ultrasound? Just a probe and that's it? No, we need to use state-of-the-art technique. We need to use different probes, different frequencies, and we need to see the whole brain on sagittal and coronal and even axial scans. And of course, we need to use additional acoustic windows like the lateral, the mastoid fontanelle and the posterior fontanelle, not only the anterior fontanelle. And of course, we don't use only grayscale, we also use color Doppler, which is very useful, not only for the vessels to evaluate the permeability of the vessels, but also to evaluate abnormalities in the CSF. And of course, you are more familiar with MRI, and we use conventional MRI, conventional sequences, and we use diffusion imaging and diffusion tensor imaging, and so on. So let's start with the bigger babies. The full-term babies. This is a full-term baby. He is relaxed, but there may be some pathology there. So thinking in life, many times we are black and white, but this is not a good thing. And I will try to tell you the radiological way. And the radiological way is gray in life, so nothing is black and white. And when we are thinking about hypoxia ischemia in the term baby, we should think first about gray matter injury, but nowadays we know that there is a lot of white matter injury. Of course, the predominant lesion is gray matter lesion. The opposite is for premature babies, white matter injury mainly, but also gray matter injury. So let's start with hypoxia ischemia, which may be mild to moderate. What happens? In order to understand the images here, there is one important message for you. For those doing pediatrics, they are familiar with the normal pattern of the different organs as a function of age. The brain is a maturing organ, and the appearance on different modalities changes as a function of age. So what is the normal appearance of the brain on ultrasound in a full-term baby? It is like this. It is like this. You see that white matter and gray matter, no important contrast between them, and here you see the basal ganglia and the lateral ventricles. Okay, so there is no big contrast on normal images in neonate. Starting by that, we can evaluate what may be abnormal. And in mild to moderate hypoxia ischemia, the first area that is harmed is white matter. So the white matter becomes brighter, and you see a very pronounced differentiation between gray and white matter. You see the cortex, which is black, and the white matter, which is brighter. If the hypoxia ischemia is more severe, in those cases, there is extension of the lesion to the gray matter. So there is a homogeneous, almost homogeneous hyperechogenicity of the brain. Concerning conventional imaging, at the very beginning, sometimes you see nothing. But if you use diffusion imaging, and here is a diffusion-weighted image, you may see restricted diffusion on different brain areas, especially in the white matter. So what are the lesions we see in the brain of children suffering from hypoxia ischemia, the mild to moderate? The lesions are like the lesions we see in watershed areas when there is hypoperfusion in the adult brain. The vascularization of a brain in a term baby is similar to the vascularization of the brain in adult patients. So here we can additionally look at the brain by using the ultrasound. We use the anterior fontanelle, which is the main acoustic window, and then we add the other acoustic windows to refine our evaluation. So this is a parasagittal image of the brain, and here this is a posterior coronal image. And you see these areas with limits that are a bit hazy, appearing hyperechogenic, and these are parasagittal lesions. This is at the very beginning, because I don't know how many of you are familiar with the brain ultrasound, but if there are anaclastic areas, because of the lesion in the brain, small lesions in the brain, confluent lesions in the brain, this appears hyperechogenic, like here and there. And progressively, there are cyst formation, there is encephalomalacia, and you see all those hypoechogenic cysts under the cortex. The most affected area of the brain is the area under the cortex, and this is quite typical. So, of course, MRI can show us the lesion, and this is a watershed area with encephalomalacia at the age of 6 months, but the hypoxia ischemia took place in the perinatal period. If the hypoxia ischemia is more severe, the areas that are affected are the areas that are having high metabolic demands. And high metabolic demands are in the cortex and, of course, in the basal ganglia. And at the very beginning, we may see lesions in the cortex. The whole cortex is affected, and this cortex normally in the neonate appears hypoechogenic. Look at those images. These are cortical areas, gyri, and you see that those gyri appear hyperechogenic compared to the white matter. And this is a completely abnormal appearance. I remind you, the cortex should be hypoechogenic, black compared to the white matter in a full-term baby. And here we have the opposite contrast. Of course, most people are more familiar with MRI, and this is the brain of the child. This is a T1 weighted image, and as this brain is mainly unmyelinated, the white matter normally appears darker compared to the cortex. This is normal appearance. And of course, on T2 weighted images, the white matter appears brighter compared to the cortex. But look at those areas. There are areas missing the cortex. Why? Because the cortex is affected, because the cortex is affected from hypoxia ischemia, so there is edema. higher signal intensity, and the signal intensity of the affected cortex becomes similar to that of the white matter, which is unmyelinated, and we have what we call the missing cortex sign. It's like missing a part of the cortex because there is hypoxia in this area. If the lesion, if the hypoxia, if the duration, if the severity of hypoxia ischemia is more severe, the areas that are affected are the basal ganglia and other brain areas, and mainly you have the list of the areas affected, which are the putamen, the ventrolateral thalami, the dorsal brainstem, the superior cerebellar vermis, and the hippocampi. Remember, I'm talking about a neonate, and all those areas are areas that are mature with high metabolic demands. If an area is not mature, there are no high metabolic demands, so this area is not affected by hypoxia ischemia. So these are the areas asking for very expensive food, and these areas are affected when there is hypoxia ischemia. And again, in order to understand what is the abnormal, and this is the most difficult thing in pediatric radiology, we start learning the normal for age for every single organ. So what is the normal appearance of the brain at the level of the basal ganglia in a full-term baby? It is like this. You see this coronal image, and you see that the basal ganglia are present an echogenicity that is similar to the white matter. So there is no contrast. They are more or less hypoechogenic, the basal ganglia. I'm telling you about a full-term baby, because in preterm babies it is completely different. And if you go there to this parasagittal scan, you see this lateral ventricle here. Here you see the choroid plexus, which is hyperechoogenic, and here you see the basal ganglia, the thalami, hypoechogenic. And this is the normal appearance. So what happens when there is severe hypoxia ischemia? The basal ganglia appear like this. You see this hyperechogenicity. Please compare with the normal child, and you see that this is absolutely abnormal. In the parasagittal scan, again, you see the thalami and the putamen and the caudate nucleus, which appear hyperechogenic. This is an abnormal appearance. Of course, if you are more familiar with MRI, it is easier for you because you have just the images coming out from the machine, in contrast to the ultrasound that you have to operate to do yourself the ultrasound. And you see here in these T2 weighted images this high signal intensity in the thalami, and you see this abnormal signal intensity in the perirholandic cortex and abnormalities in the hippocampi. And this is a typical appearance of severe hypoxia ischemia. And here is a case from an adult patient. This patient had this MRI at the age of 30 years old, and when I've seen those images, I said, okay, let's go back to his perinatal history. And the perinatal history was severe hypoxia ischemia, and this is the result. You see that there is a shrinkage of the basal ganglia. You see this encephalomalacia area at the level of the putamina. You see this abnormal signal intensity in the perirholandic cortex. And of course, you see similar findings in this T1 weighted image. And if you look at this parasagittal scan of this FLIR image, you see this abnormal signal intensity at the level of the corticospinal tract. And this is, of course, a typical appearance. But sometimes things are more severe, even more severe, and then the whole brain is affected. And in those cases, you see on ultrasound, abnormal signal intensity, of course in the white matter, of course in the cortex, and you see this abnormal echogenicity at the level of the basal ganglia, which is quite typical. And if you go for MRI, of course, MRI is necessary. I told you that the ultrasound is the first step, is the emergency, is what we do at bedside, but then we proceed with MRI, and of course, we go into details, and you see that there are abnormalities everywhere. You see areas with cystic encephalomalacia all over the brain, in the white matter, in the basal ganglia, everywhere there missing cortex sign, and this is the most severe asphyxia. And later on, at the age of 4 months, this brain not only presents multiple encephalomalacia area, but also there is a shrinkage of this brain, and of course, the prognosis of this child is very bad. But at the very beginning, if you are familiar with this technique and you see those images, you almost know the prognosis and what you are expecting to see on MRI, of course, in more details. So, that was the main findings and the whole thing, how we proceed with full-term babies. Let's go now to another population which is more fragile, more difficult to deal with, and here the ultrasound plays a very important role because remember, those babies are very fragile and it is very difficult to bring them at the MRI unless you have an incubator which is appropriate for the high field, an MR compatible incubator, and which is very expensive to have it. So you deal with ultrasound at the very beginning and then you continue. And again, just to remind you that life is not black and white, it is gray in radiology, and here in premature babies, we think about white matter injury, hypoxia, ischemia, but also there is gray matter injury. So, if the hypoxia ischemia is moderate, and moderate, you know that those babies are very immature, and they are immature not only in the brain, they are immature in the lung, and they are immature in the kidneys, in every organ. So these babies are suffering easily from hypoxia ischemia because the lungs are not mature. And there are two main axes of lesions that appear in premature babies. The first are the lesions of periventricular leukomalacia, and the second is the brain hemorrhagic disease, and we will go through those abnormalities. But if there is profound asphyxia to those babies, we will see abnormalities like in the full-term babies, affecting mainly the putamen, the high metabolic areas, the areas with high metabolic demands, the putamen, the ventrolateral thalami, the dorsal brainstem, and the hippocampi. But if you go down to this list, you will see that the perirolandic cortex is not affected, the superior cerebellar vermis is not affected, and the posterior part of the internal capsule are not affected because those areas are not mature. And since they are not mature, they don't have high metabolic demands, and those areas are affected in full-term babies. So this is not the most common. The most common is this, the periventricular leukomalacia, and the brain hemorrhagic disease with the germinal matrix hemorrhage, the intraventricular hemorrhage, parenchymal venous infarction, and post-hemorrhagic hydrocephalus. So what are our imaging protocols? As I told you before, we start with ultrasound. We go at the bedside and we do the ultrasound, and we start with an ultrasound during the first 48 hours in order to avoid missing, especially the brain hemorrhagic disease that takes place very early. And then if we see nothing and the baby is stable, we repeat our ultrasound at 1 week. And depending on the prematurity, we repeat the ultrasound for babies, for gestational babies, every week. And if there are abnormalities, we tailor our exam to the demands of the baby. We do an MRI at 40 gestational weeks, the term equivalent, when the baby is more stable, and we want to see what happened to the brain of this child in order to give a prognosis. And then, at the age of 8 months, corrected age, it is very important to correct for gestational age when we are talking about premature babies, and at 2 years of age, when the maturation process has not almost completed, but the most areas of the brain are mature. And of course, depending on what we found at the initial imaging, we tailor our exams. So let's start from the periventricular leukomalacia. Here, this periventricular leukomalacia is hypoxic ischemic lesion, and this lesion is related with the vascularization of the brain in premature babies. And the vascularization of the brain in premature babies is not the same as in term babies. The brain is vascularized by terminal vessels, which are the long penetrating arteries and the short penetrating arteries. And these vessels are end vessels. There is no communication between them. So there are areas that are affected when there is hypotension or hypoxia ischemia, the end of those arteries. And the end of those arteries of the long penetrating vessels is the periventricular white matter. So when there is hypoxia ischemia, because of the end arteries, the long penetrating arteries, there is no way to get blood there. So this area is mostly affected, and this is the periventricular area, especially the posterior part of the brain. And there, in hypoxia ischemia, there is necrosis of all cell elements in this area. And when there is less severe hypoxia ischemia, then the areas that are affected are the end of the short penetrating arteries and between the long penetrating arteries. And what is affected in those cases? In those cases, what is affected are not all cell population, whatever is around. The thing that is affected are the precursors of oligodendrocytes. And I remind you that the oligodendrocytes are very important for brain maturation, because these oligodendrocytes provide myelin, provide the dressing of the axons. So if the precursors are dying, there is no myelination. And of course, if there is no dressing, finally the axons die, and we have a small quantity of white matter. So I talked to you about two kinds of periventricular leukomalacia. The term is not correct. The term periventricular leukomalacia should apply only on the lesions we see around the ventricles. And this is the focal periventricular leukomalacia. But we use this term erroneously for another kind of lesion which affects the oligodendrocytes. And this is the diffuse form of periventricular leukomalacia. In those cases, we have a decrease in the white matter, and there is no increase in the size of the brain. So let's go to see what are the imaging findings. Let's start with the most severe form, which is the focal periventricular leukomalacia. And as I told you, the areas that are affected are around the lateral ventricles. And here is a coronal scan showing this hyperechogenicity posterior to the occipital horns. And if you see these areas, these are not only hyperechogenic, these areas are heterogeneously hyperechogenic. And this is bad news. And of course, if you use a parasagittal scan, again, you see this heterogeneous hyperechogenicity. And progressively, you will see encephalomalacia and the formation of the cyst, and we will see the images. What about the diffuse form of periventricular leukomalacia? here the oligodendrocytes are all over the brain, all over the white matter, and if they are affected, there is a homogeneous thing. And do we see something with ultrasound? The answer is mainly no, we see nothing. So you do your ultrasound, you see nothing, and you say, okay, I don't need to follow up this baby. That's why we do an ultrasound at the intensive care unit every week to those children. So it is important to see what happened. Let's continue with the focal form of periventricular leukomalacia. At the very beginning, we see this heterogeneous hyperechogenicity, and later on, something that is more easily recognizable, those cyst lesions with alternating with hyperechogenic areas. The cyst lesions are lesions, cystic, encephalomalacia, and these hyperechogenic areas are multiple coalescence microcysts. So this is the typical appearance of a focal form of periventricular leukomalacia. And of course, if you go for the MRI, you will see these cyst formation areas with high signal intensity on T1 weighted sequences appearing with low signal intensity on T2 weighted images, and you see that the areas that are affected is the periventricular white matter, like in here, and of course you see that there is no enough tissue around, between the lateral ventricles and the cortex and the gray matter, and this is because there is distraction of the white matter. And please look at the internal capsule. This is a very important finding. At 1 month of age, you should see in a neonate a high signal intensity on the posterior limb of the internal capsule. This is a normal finding. This is a finding saying that there is myelination of the internal capsule. Sometimes you may miss this finding, and this is bad news for the motor prognosis of those children. And this means that the internal capsule is secondarily affected. There is Wallerian degeneration at the corticospinal tracts, and those babies have a worse prognosis, a bad motor prognosis, additionally to the other problems. So if you see a premature baby, please look at the internal capsule. Don't forget the internal capsule in those areas. Here is another case, and this MRI was performed later on, and you see that there is almost no white matter between the lateral ventricle and the cortex, and this is my sign. I call it the kissing cortex sign, because there is no tissue between the cortex and the lateral ventricles. So the lateral ventricles, especially the occipital horns, are looking like kissing the cortex here. And of course here you may see this cyst formation because there is distraction of the white matter around the lateral ventricles. And if you look at this image, you see that there is an irregular angular outline of the lateral ventricles. You know why? Because the white matter is distracted, and then the walls of the lateral ventricles are distracted too, and there is a formation of a new wall of the lateral ventricles made of these lesions. So you will see thinning of the white matter, abnormal, irregular outline with angular borders there, and of course you may see signal abnormalities in the white matter. And if you use fractional anisotropy maps, you see that there is thinning of the white matter tracts in this case compared to this normal subject. Never forget the internal capsule. This is very important, and I will say it again and again, and this is a premature baby. This baby was an extremely premature, born at 29 gestational weeks, and the MRI was performed at corrected age of 1 year. So let's have a look at this midline sagittal scan. This is 1 year old. The corpus callosum looks bright. What he has as corpus callosum looks myelinated, but this corpus callosum, believe me, is very thin for the age of this child, and I can say that because I'm familiar with the normal appearance at this age. Of course, I can measure area, volume, whatever you want. So this baby presented with cerebral palsy, chondroplasia, epilepsy, and cognitive impairment. And concerning the motor problem of this child, the answer is here. Look at the internal capsule. This is a T2 weighted scan, and you see that this internal capsule is bright. You know that myelinated white matter should appear dark, and here at this age we would expect to have this low signal intensity at the level of the internal capsule, and here this internal capsule is bright. And of course, if you look at the lateral ventricles, you see that there is enlargement of the lateral ventricles. There is this irregular border, this angular border of the lateral ventricles, and again, the lateral ventricles are kissing the cortex. Here is the cortex, there, and you see the cortex is kissing the lateral ventricles, or the lateral ventricles are kissing the cortex because of the lack of white matter here. Okay, as radiologists, we use our eyes, and after a certain age, after the age of 20, we are using glasses. But we trust our eyes, and we say this is normal, this is abnormal, and we are very proud of this. But when I started doing voxel-wise analysis of my imaging and going at the voxel level and see what happened by using those complicated techniques and statistics and whatever, I said, oh my God, my eyes are not very good. It's probably the age. No, it's not my age. It is the fact that we see big things. Of course, in everyday life, seeing big things is the most important to give a diagnosis. But if we want to proceed with science and understanding of certain entities, it is very important to look at a voxel level. And for pediatric radiologists, it's more important because we see how the brain is maturing as a function of age. With these images, these color images, we can demonstrate how the cortex is becoming mature and larger as a function of age. And if you want to know what happened at the level of the gray matter in children with periventricular leukomalacia, the most severe form, the focal form, and you go at the voxel level and you compare premature babies with focal periventricular leukomalacia with premature babies without this lesion, apparently normal, you will see some abnormalities. And the abnormalities are not thinning of some structure. It is the opposite. It is hypertrophy of certain areas. Here we assign with color the differences, and there is hypertrophy in the frontal superior orbital areas, in the lingual gyrus, in the postcingulum, in the putamen, and the thalamus. And you would not expect this finding, because if you lose substance, if you lose white matter in the brain of a child, you would expect to lose gray matter. But you know something? That is a nice Greek term we use in pediatric radiology for the brain. The word is plasticity. Plasticity means that the brain, the immature brain, has a great potential to overcome certain problems by hypertrophying some areas. So the end result in a premature baby is less severe than the end result in a mature brain or in an adult brain. And here is the answer. There is, because of plasticity, there is hypertrophy of certain areas in order to overcome the problem at a certain level. So this is a typical case of focal form of periventricular leukomalacia, and this is a typical form of diffuse periventricular leukomalacia. There is enlargement of the lateral ventricles, but the enlargement is characterized by regular outlines of the lateral ventricles, because here there is no a certain area that is affected. The whole white matter is affected. There is the whole white matter is smaller compared to a normal child, and this is easily seen on later MRIs. And of course, if you use more sophisticated techniques, you can see the thinning of the white matter tracts. Of course, you should compare with what is normal for age. And if you do tractography, for instance, you may see this miserable corpus callosum, this feathery corpus callosum, which is thin for the age of the child. And, but there is no abnormality of the outlines of the lateral ventricles or of the white matter, any abnormality in signal intensity. And again, if you want to go at the voxel level and look what happened in premature babies with the diffuse form of periventricular leukomalacia, you may see areas that hypertrophy, like all those areas, and areas that decrease in size. And please have a look at the temporal lobe. Here there is a decrease in the gray matter of the temporal lobe, and those babies have very often cognitive problems, and these are related with these affected areas. So let's try to make the difference between the two entities. What are the differences between the focal periventricular leukomalacia and the misnamed periventricular leukomalacia, the diffuse form? In the focal form, the ischemia is at the end of long penetrators, and there is, in the other case, there is between the long penetrators and at the end of the short penetrators. This is less severe, and nowadays is more common than the focal form. In the focal form, there is focal necrosis. In the periventricular leukomalacia of all cell elements. In the diffuse form, there is apoptotic cell death of the precursors of the oligodendrocytes. In the focal form, there is cyst formation visible on the ultrasound as hyperechogenic areas at the very beginning and cyst formation later on. In the other form, there are no sound findings at the very beginning. So you may say, no problem, we stop the ultrasound, but this is not good manners for those babies. And finally, in the focal form, there is those babies develop cerebral palsy. In the diffuse form, most of the babies present with cognitive impairment. So sometimes you may see some kind of lesions in premature babies again, like bright spots at the ultrasound. This is not a common finding. Don't go with the ultrasound looking for those bright spots. And we don't know what it's about, but if you do MRI, you will see that there is a kind of rosary of these bright spots on T1 weighted images around the lateral ventricles, and these appear with low signal intensity on T2 weighted sequences. These bright spots are very pronounced in very young babies around birth and then progressively disappear. And these bright spots may be seen also in term babies, but these are more frequently seen in premature babies. And we don't exactly know what it's about. We know that there is probably coagulative necrosis, and we see this low signal intensity on T2 weighted sequences, but these babies are continuing life, and they are doing quite well compared to the other babies with periventricular leukomalacia. I told you that we don't know what it's about because we don't have the histology in large series. If I may give you my experience, my clinical experience, I would say that this is a periventricular leukomalacia a minima, a minimum periventricular leukomalacia, because they are looking like the spots we may see in periventricular leukomalacia, the focal form, and I've seen several cases in twin babies, the one presenting with typical periventricular leukomalacia and the other with bright spots. But this is my personal experience. Let's go now for the brain hemorrhagic disease. And the brain hemorrhagic disease is related to what we call germinal matrix. You know that life is born next to the sea. It is very important. And the populations, the different populations of the brain, that especially the neurons, are born near the water, near the lateral ventricles. Under the lateral ventricles, there is what we call the germinal matrix, all the way from anterior to posterior, and this is the motherland, providing with neurons, providing with astrocytes and other cells, but especially with neurons. And this motherland regresses as the cortex is formed, and at the age of premature babies, like 26, 29, 30 gestational weeks, there is a small quantity of this germinal matrix between the head of the caudate nucleus and the frontal horns. And this germinal matrix has high metabolic demands, so this germinal matrix is highly vascularized. But the vessels of this germinal matrix are very fragile, and they bleed easily. Imagine those babies that suffer from hypoxia ischemia. They are giving oxygen and respiratory assistance, and they have problems with the tension and everything. It is very easy for those vessels to bleed, and these children may present hemorrhage at the level of the germinal matrix. So let's go to see what's happened. At the very beginning, when there is bleeding, and I told you that this germinal matrix regresses, and what it remains, it is the germinal matrix under the frontal horns. You may find something like this in ultrasound. I lost my mouse. No. You see the mouse? Huh? Where is? Okay. The mouse is here, so don't worry. So this is a coronal scan at the level of the frontal horns, and you see this hyperechogenic material here. And this is bleeding at the germinal matrix, okay? And this bleeding at the germinal matrix is not always staying at the germinal matrix. It can go into the lateral ventricles and become an intraventricular hemorrhage, okay? So, and then if blood is into the ventricles, you know blood is very important, but blood can be very bad when it goes in places where it's not allowed to go, because the blood can create a ventriculitis and obstruction of CSF flow, and then you may have hydrocephalus. So it starts as a subependymal bleeding into the germinal matrix, and progressively there is a flooding with blood into the lateral ventricles, and this blood may appear hyperechogenic. Okay, if I were you, I would ask a question. Is there any way to know what is happening, or to in advance, if there is blood, it would be blood goes into the lateral ventricles. Here we are at the level of subependymal hemorrhage, germinal matrix, and there is no way to say if there is a little quantity of blood into the lateral ventricles. These are the choroid plexuses here. There is one way, by using your color Doppler. You are familiar with color Doppler, using it in vessels. But you know, if there are blood particles, small quantity of blood particles into the CSF, you can check it with ultrasound and see at the level of the aqueduct of Sylvius an alternation of red and blue, which is the systole-diastolic CSF flow. And as the particles are going up and down, you encode flow, red or alternating red color with blue color. And this is very important to know very early if this is going to be an intraventricular hemorrhage. Here, a more severe case, you see that the blood, this hyperechogenic material, starts in the lateral ventricles and then goes into the third ventricle. You see here a very nice image from the posterior fontanelle. You see easily the occipital horn, and you see this hyperechogenic material into the lateral ventricle, and this is another view from the posterior fontanelle. And this is a child who developed later on hydrocephalus because of the irritating blood into the lateral ventricles. Okay, this is the only problem, this is the only complication of this bleeding? The answer is no, because you may have hydrocephalus, but you may have other problems. And this other problem is named venous infarct. And what is this venous infarct? This is a coronal scan. You see the frontal horns, and you see the internal vein on each side. And this internal vein is very important because to this internal vein are drained the medullary veins of the brain. So if you have bleeding into the lateral ventricle and there is an enlargement of the lateral ventricles, these enlarged lateral ventricles compress this internal vein. So what you are going to have? Drainage problem, and of course a venous infarct, because the medullary veins are not able to be drained by this terminal vein. Is there any way to say that this baby is about to develop a venous infarct and to do something, the clinician? The answer is yes again. If you don't see this symmetrical terminal vein and you miss it on one side, you can say that this baby is going to develop a venous infarct. And this is later on with dilatation of the lateral ventricle, completely deformed. You see this echogenic material, and at the periphery of the lateral ventricle, there is an echogenic lesion, and this is a venous infarct secondary to the intraventricular bleeding. So it is very important to go into details and do a state-of-the-art exam. Here is a case, an extremely premature baby, very low birth weight, and these are the most fragile babies. These are the babies that you should examine the first 48 hours because you see the hemorrhage at around 48 to 70 hours. And this is the first ultrasound. These are coronal scans, and this is a brain that is not very curly. And you would say, oh, there is pachygyria, oh, there is a problem of maturation. But this is the appearance expected for the age. The brain is loose, is not very curly, and you see also the lack of operculization of the sylvian fissure. But again, this is normal for age. This is an absolutely normal appearance. And you see the loose brain here, but this is again absolutely normal. And later on, we see this hyperechogenic material into the lateral ventricles, even into the temporal horns, which are not visible on ultrasound in babies, and this baby developed venous infarcts because of the compression of the terminal vein. So the result may be very, very, very bad. Of course, the MRI may show the lesion with the alternations of signal intensity because these venous infarcts are hemorrhagic with areas of low signal intensity, high signal intensity. This is expected, and this is a typical appearance on MRI. When we are dealing with intraventricular hemorrhage, it is very important to look at the lateral ventricles and to look at the internal capsule, if it is affected. And this is very important for the motor prognosis of the child. And we shouldn't forget this internal capsule. This is a case, this is a venous infarct extending into the internal capsule, and the motor prognosis, this affected the motor prognosis of that child. So what about hydrocephalus? You know, hydrocephalus is a progressive thing, and it is very important, and many times we have the clinician asking, should I drain the hydrocephalus or no? And is there any way to say you should drain it or not? Yes, the answer is yes. We use color Doppler, and we measure the spectra, we evaluate the spectra into the anterior cerebral artery, and we use this delta RI. We measure the resistive index without compressing the anterior fontanelle, and then we compress the anterior fontanelle, and again we measure the index after compression. And if this formula gives us less than 30%, the child doesn't need any shunt. If this formula gives us 45%, so the child needs to be drained. So we have a way to say the clinician, to guide the clinician and tell him, go on for the shunt to this child. Of course, this is a terrible, a horrible case. That was a baby, a very premature baby, 26, almost 27 gestational weeks, and the parents did not allow us to do anything to the child, so he started with intraventricular hemorrhage, with a venous infarct there, and then progressively developed a huge hydrocephalus. We were not allowed to drain the baby, and you see that it's like an anencephaly because the whole brain is the dilated lateral ventricles, and this is here, this is here a trapped fourth ventricle and no parenchyma in the cerebellum. So the difference is sometimes people are asking what is the difference between the focal form of periventricular leukomalacia, because we have encephalomalacia there, and the venous infarct due to intraventricular hemorrhage. Focal periventricular leukomalacia is bilateral and in most cases symmetric. The infarct is always unilateral, or if it is bilateral, it's asymmetric, and the lesions are more diffuse on ultrasound. There is no gliosis in PVL, and in the infarct, the lesion is triangular, echogenic, next to the ventricles, and it may be anterior, and there may be perilesional gliosis. For many years, when I started pediatric radiology back the last century in Paris, we used to look at the brain, the upper level, the second floor, and we didn't pay attention to the cerebellum. Nowadays, we know that the cerebellum is a sensitive organ, and in prematurity, it is the high season for developing of the cerebellum, and it is very important to go and look at the cerebellum because we have problems at the cerebellum in those premature babies. And we have problems because at the periphery, at the superficial areas of the cerebellum, there is this granular layer, which is the motherland. It's a kind of germinal matrix for the development of the rest of the cerebellum. So by looking children with periventricular leukomalacia, we found that in some children the cerebellum was shrinking. Instead of growing, was shrinking. And these babies were very premature babies with hypotension, severe hypotension in the history, and a large patent ductus arteriosus. And those babies presented this kind of floating cerebellum, which is acquired. It was not it was a hypoplasia acquired, and this may happen because due to severe hypoxia ischemia, this superficial granular layer may be affected, with additional risk factors like hypotension and a large patent ductus arteriosus in very premature babies, you may see the cerebellum disappearing, and this is not something congenital or something different. So, do we see hemorrhage in the cerebellum? The answer is yes, provided that you use the right window. You cannot see the cerebellum from the anterior fontanelle. No way, forget it. Go by the mastoid fontanelle, go by the posterior fontanelle, and in those cases you may see this hyperechogenic, again I lose my mouse, hyperechogenic cerebellum, and it may be unilateral, and the bleeding is in the germinal matrix. And in these cases, the germinal matrix is the superior, is the superficial granular layer. And you may see bleeding, of course, with MRI, with this low signal intensity later on, and you see this affected cerebellar hemisphere. And of course, with MRI, you see this encephalomalacia-like, with ultrasound, you see this encephalomalacia-like appearance of the cerebellum. Of course, you may see germinal matrix hemorrhage at the level of the germinal matrix of the fourth ventricle, and in those cases, the vermis is affected. There is another way to be affected the cerebellum, and this is more diffuse, and this happens mainly to the premature babies, to the extremely, I'm finishing, to the extremely premature babies, and this happens after intraventricular hemorrhage. I told you that blood is very important, but blood is very bad. And when you have intraventricular hemorrhage, this blood contaminates the whole CSF spaces and goes everywhere. It goes into the ventricles, into the subarachnoid spaces, into the cisterna magna, and it goes at the superficial, it affects the superficial layer of the cerebellum. So this blood is toxic to the superficial granular layer, which is supposed to produce cells for the internal layers. So the contact of blood, of the byproducts of blood with this superficial granular layer destroys this layer, and there is a progressive, instead of maturing the cerebellum, there is again a progressive shrinkage of the cerebellum. This is day 3. Mastoid fontanelle, you see a very nice cerebellum, and progressively you lose your cerebellum. That was a child who presented 28 gestational weeks, presented intraventricular hemorrhage, and this affected the superficial granular layer of the cerebellum, and there was this floating cerebellar hemispheres. You see that these are very small. Here you see in this parasagittal scan, and if you use susceptibility imaging, you may see this signal loss at the surface of the cerebellum because these blood byproducts go and stay at the surface of the cerebellum. So I think that I have to conclude, okay? The messages are very many, but my main message is, if you are not familiar, try to at least to be able to read the ultrasound, to know what is the offer, what are the possibilities of ultrasound, because this is the first line exam, provided that you do it correctly, state of the art. Otherwise, you miss most of the things. The MRI is very important, provided that your baby is stable, especially the very premature babies. And if you have an MR-compatible incubator, you are lucky. But of course, it's not easy to repeat the MRI several times. You can repeat the ultrasound anytime, many times, no problem. Of course, another message is that it is very important in pediatrics to know what is normal for age. And you've seen the differences between the preemies and the full-term babies. And then it is very important to remember that the time of hypoxia ischemia lesions depends on the brain maturation. Lesions are completely different in mature babies compared to the premature babies. I will stop here because I think that we don't have time for any cases, if there are questions or comments.
Thank you very much, Maria, for a great session. If there are any questions to Dr. Argyropoulou, please go ahead. I think it was fantastic. I have learned a lot because I don't deal with babies, so for me, and it was very clear. And I think the key message, as you say, is to develop an excellent technique in ultrasound to examine these preemies and term babies. Thank you so much. Muchísimas gracias. ¿No hay preguntas para la doctora? No, todo muy claro.
No, they are tired.
They are.
It was a marathon the whole day.
It was.
They are brave enough to
are.
attend so many lectures.
Hay una pregunta allí. There is a question.
Okay, okay.
¿Sí? ¿Tienes una pregunta?
Yes.
Buenas tardes, muchas gracias por la hermosa presentación, muy didáctica. Quisiera saber, en su experiencia, ¿cuál es el protocolo de seguimiento de los pacientes que presentan isquemia o hemorragia en el ultrasonido transfontanelar?
Your protocol for follow-up in babies with infarcts or
hemorragia intraventricular, me refiero al tiempo de seguimiento. ¿Cada cuánto se tiene que repetir el ultrasonido?
How often do you follow up patients with intraventricular hemorrhage and or infarcts?
Okay, the answer is it depends. It depends on how things are going. If you have a developing hydrocephalus, sometimes you do the exam twice a day, because they are asking you, should I drain or not? If you see an established infarct, for instance, a venous infarct, the harm was done. So you don't go every day for ultrasound. But the exams in those babies are tailored to what you see on its ultrasound. Especially for hydrocephalus, you may do that twice a day, just for treatment reasons. If you see a developing hydrocephalus due to hemorrhage, you should always repeat your exam in order to see the terminal vein, so you go the day after. And you are always in contact with the clinician. There is a very close collaboration. So your question is very, very important, but it is like the question I asked to my mom. When I started doing something, for instance, a Greek moussaka, I never did that. I asked my mother how much cell I put to the moussaka, mom, and she said, you use your eyes, you use your experience, okay? So it is something that I cannot answer. It depends, it is the answer, okay?
Muchas gracias. Entonces, ya saben, es como una receta que uno le pide a la mamá, que te dice, tienes que tú llegar a la conclusión de qué es lo mejor. Bueno, ¿hay alguna otra preguntita? Sí.
No sé si le das la, para que no se entienda. A la doctora. No, a la doctora. Para que le traduzca. Es que es un poquito larga la pregunta, no sé si quiera que le traduzcan directamente.
Sí, dila en inglés.
Ok.
De una vez.
Bueno, yo veo muchos pacientes pediátricos, pero ya con edad más avanzada.
¿Cómo?
Es que es muy largo el
Sí.
comentario, no sé si le den para que le estén traduciendo a ella.
Ah, ya,
Sí.
muy bien, sí. Entonces.
Para que le traduzcan. Sí.
This is for the translation, because it's a long question, a commentary that he's making.
That I will hear.
Yeah. Let's see. Ok.
Gracias. Le comentaba que yo veo muchos pacientes pediátricos por trastornos de desarrollo. Trabajamos con instituciones del CRI y del CRIT que ven pacientitos que tienen trastornos de motilidad o de psicomotriz. Y muchos de ellos que los veo tienen trastornos de mielinización y una gran mayoría de los que estoy viendo tienen trastornos de eventos hipóxico-isquémicos y algunos hemorrágicos perinatales. Pero ya yo los veo cuando tienen 3, 4, 6 años. La pregunta es, nosotros nos apoyamos mucho con la angiografía 3D TOF y con la secuencia eco de gradiente SWAN, con la que detectamos incluso a veces muy pequeños depósitos de hemosiderina en las regiones subependimarias que a veces nos explican las áreas de malasia periventricular que encontramos. O en pacientitos que tienen colpocefalia marcada, también encontramos mucha relación con eventos hipóxico-isquémicos hemorrágicos antiguos o perinatales. En estos pacientes también les hemos estado haciendo otras 2 secuencias, que es la espectroscopía y las tractografías, y hemos encontrado que tienen trastornos que se relacionan con lo que vemos también en esclerosis mesial sin necesidad de que tengan epilepsia, o bien que tienen trastornos de degeneración valeriana que pensamos que están relacionados con todo eso. No sé si ustedes hayan hecho algo semejante y si han encontrado hallazgos como los que hemos encontrado.
I had some difficulty in understanding the whole thing because I don't hear very well. If I understood well, you see a large number of patients with problems, but you see them later on.
From 3 to 6 years
Yes,
old.
and I didn't very well catch the thing about the sequences they use.
Sí. ¿Cuáles son las secuencias que utilizas para...?
Sería la SWAN, que es la
SWAN,
eco de gradiente 3D que utiliza General Electric,
3D Echo Sequence by General
la 3D TOF, TOF,
TOF, Angel.
Yeah.
Those are the things he uses most.
And susceptibility? No, you didn't say susceptibility.
SWAN is susceptibility
Sí,
weighted. Yeah.
sí.
SWAN
Es un T1.
What do you
es un-
find on those sequences?
SWAN es un
No, what do you find on those sequences?
¿Qué es
What
lo que
are
encuentras en esa secuencia?
tatuajes de hemosiderina, depósitos principalmente en las regiones subependimarias.
Deposits of hemosiderin mostly in subependymal areas
yes, yes.
Y en las regiones periventriculares.
and in periventricular region.
Yeah, but this is a common finding, you know. It is a common finding because these hemorrhages, the premature babies, are bleeding very easily, and you may even have a subarachnoid hemorrhage that you miss with imaging because you don't do MRI to those children. And you will see this kind of deposits of hemosiderin later on if you use a sensitive technique. And if you use susceptibility imaging, it is easily found, more easily than with gradient echo imaging. But I'm not surprised that with your finding. I'm not surprised because in premature babies we see this kind of things by doing MRI. Usually, I don't know if you can join your results with the perinatal history of those babies, but this kind of bleeding, you see it more frequently in extremely premature babies. These are the most sensitive. So if you see your finding, go back to the perinatal history and ask what happened, if you have the possibility, or ask the parents what was the gestational age of birth. I mean, if this is a very premature baby, it happens. It happens.
Ok, gracias.
Thank you very much.
Thank you.
So this was a great session. Thank you very much. A todos, muchas gracias y un fuerte aplauso para la doctora.